Welcome to Roadmap to Residency Step 2 Board Prep Series. Today we are diving into venous thromboembolism, one of the highest yield topics you will encounter on your board exam. We are going to walk through real question stems, break down the answer choices, and give you strategies you can apply on test day. This is not a lecture, it is a question-based walkthrough. Let us get started. Here are our learning objectives for today. By the end of this video, you should be able to recognize classic question stems for deep vein thrombosis and pulmonary embolism. You will learn how to approach anticoagulation duration questions and know exactly when an inferior vena cava filter is the right answer. We will walk through multiple choice questions with full explanations, and we will give special attention to the oncology angle for pulmonary embolism because the boards love testing cancer-associated thrombosis. For the foundational knowledge behind these topics, make sure you review the venous thromboembolism chapters in your preferred board review resource. Before we jump into questions, let us review the buzzword associations that signal venous thromboembolism on the boards. When you see unilateral leg swelling with calf tenderness after immobilization or surgery, think deep vein thrombosis. When you see sudden dyspnea with pleuritic chest pain and tachycardia in a patient with cancer or after surgery, think pulmonary embolism. And when the question describes an unprovoked clot in an older patient with weight loss and a new mass, think cancer-associated thrombosis. These associations will help you narrow down the diagnosis within seconds of reading the stem. Here is our first case. Read through this stem carefully. A 52-year-old woman, 5 days after a total hip replacement, with progressive left leg swelling and pain. The left calf is 3 centimeters larger than the right with warmth and tenderness. She is hemodynamically stable. Before you look at the answer choices, identify the key clues. Post-surgical unilateral leg swelling, calf asymmetry. This is a textbook deep vein thrombosis presentation. The question asks for the most appropriate next step. Think about whether you need a screening test or a definitive test. The correct answer is B, compression ultrasound. Here is why. This patient has a high pre-test probability for deep vein thrombosis. She is post-surgical with classic signs. When pre-test probability is high, D-dimer is not helpful because it is often elevated after surgery anyway and gives you no useful information. Go straight to the definitive test, which is compression ultrasound. Choice A, D-dimer, is a trap. The boards want to see if you know that D-dimer is only useful in low pre-test probability patients. Choice C, starting heparin empirically, is premature in a stable patient. Always confirm before you treat when the patient is stable. Choice D is looking for a pulmonary embolism, which is not what this patient is presenting with. And choice E, placing a filter, is only for patients who cannot receive anticoagulation. This concept is tested heavily, so review the Wells criteria in your board prep materials. Now let us tackle pulmonary embolism with an oncology twist. Read this stem. A 63-year-old man with pancreatic cancer on chemotherapy presents with acute dyspnea and pleuritic chest pain. His heart rate is elevated, blood pressure is low normal, and oxygen saturation is 88%. The boards are testing two things here. Can you recognize pulmonary embolism? And do you know that cancer is a major risk factor? Think about what imaging you would order. The correct answer is C, computed tomography pulmonary angiography. This is the gold standard for diagnosing pulmonary embolism in a hemodynamically stable patient. Let me walk you through the distractors. Choice A, D-dimer, is not helpful here because pretest probability is high and cancer alone can elevate D-dimer. Choice B, ventilation perfusion scan, is an alternative if the patient has a contrast allergy or kidney problems, but it is not the first choice. Choice D evaluates for deep vein thrombosis, but does not confirm what is happening in the lungs. And choice E, chest X-ray, is usually normal in pulmonary embolism and would delay diagnosis. The oncology connection is critical for your boards. Cancer patients are hypercoagulable, and the preferred anticoagulation for cancer-associated thrombosis is either low molecular weight heparin or a direct oral anticoagulant, not warfarin. Review this in your hematology and oncology chapters. Let us review the management pearls for pulmonary embolism because the boards stratify treatment by severity. Massive pulmonary embolism means hemodynamic instability with systolic blood pressure below 90. These patients need systemic thrombolytics like alteplase. Submassive pulmonary embolism means the patient is stable but has right ventricular dysfunction on imaging or elevated cardiac biomarkers. Standard anticoagulation is the treatment, with catheter-directed therapy considered in select cases. Low-risk pulmonary embolism means stable vitals, no right heart strain, and these patients may even be managed as outpatients with a direct oral anticoagulant. Know this stratification for your exam. Here is Case 3, testing anticoagulation duration. A 45-year-old man with no medical history gets a deep vein thrombosis after a 10-hour flight. He completed 3 months of rivaroxaban and the clot resolved. What do you do next? The single most important question to ask yourself is, was this clot provoked or unprovoked? Identify the provoking factor before you look at the answer choices. The correct answer is B, discontinue rivaroxaban now. Here is the logic. This was a provoked deep vein thrombosis. The provoking factor was prolonged immobilization during a long flight, which is a transient risk factor. For a first-time provoked venous thromboembolism with a transient risk factor, the standard treatment duration is 3 months. He has completed that, and the clot resolved. There is no reason to continue. Choice A, indefinite therapy, is for unprovoked clots or those with persistent risk factors like cancer. Choices C and D extend therapy unnecessarily and expose the patient to bleeding risk. Choice E, hypercoagulability workup, is generally not recommended for a first provoked event. The board loves this concept. Provoked equals 3 months. Unprovoked equals consider indefinite. Review the anticoagulation duration guidelines in your hematology section. Case 4 tests your knowledge of inferior vena cava filter indications. A 70-year-old woman has an acute proximal deep vein thrombosis, but also has an active hemorrhagic stroke. Her neurosurgery team says no anticoagulation for at least 4 weeks. The question is, how do you prevent a fatal pulmonary embolism when you cannot anticoagulate? Focus on the absolute contraindication. The correct answer is C, place a retrievable inferior vena cava filter. This is the classic board scenario for a filter. Acute venous thromboembolism plus absolute contraindication to anticoagulation. An active intracranial bleed is one of the strongest contraindications. Choices A and B, any form of heparin, could be fatal with an active brain bleed. Choice D, aspirin, does not prevent venous thromboembolism. Choice E, observation, is dangerous because a proximal femoral vein clot has a high risk of embolizing. Key pearl, retrievable filters should be removed once anticoagulation can be safely started. The boards may ask about this as a follow-up. Also remember, the filter prevents embolization but does not treat the existing clot. Review this in your surgery and hematology board prep resources. Here is a bonus question testing the association between unprovoked clots and cancer. A 58-year-old woman with no risk factors has bilateral pulmonary emboli. The correct answer is B, age-appropriate cancer screening. Unprovoked venous thromboembolism in patients over 50 should prompt you to think about occult malignancy. The boards test this association frequently. Choice A is incomplete because you need to look for the underlying cause. Choice C is not the priority for a first unprovoked event in an older patient, where cancer screening is more important. Choice D is too invasive without other indications. Choice E is problematic because antiphospholipid antibodies are affected by anticoagulation and should not be tested while on therapy. This is a common trap answer. Review the approach to unprovoked venous thromboembolism in your hematology chapters. Let us wrap up with a summary of the key test-taking strategies you should take with you. First, when pre-test probability is high, skip the D-dimer and go straight to definitive imaging. Second, always determine if a clot was provoked or unprovoked to decide the duration of anticoagulation. Provoked means 3 months. Unprovoked means extended therapy. Third, inferior vena cava filters are the answer only when a patient has acute venous thromboembolism and absolutely cannot be anticoagulated. Fourth, in pulmonary embolism questions, always assess hemodynamic stability. Stable patients get computed tomography angiography. Unstable patients may need thrombolytics. These 4 rules will help you answer the vast majority of venous thromboembolism questions on your boards. That is it for today's walkthrough. If this video helped you feel more confident about venous thromboembolism questions, please hit that like button and subscribe to our channel. We release new high-yield question walkthroughs every week, covering the most tested topics on Step 2. And if you want personalized help with your board prep or residency applications, Visit roadmap2residency.com, where our expert tutors and residency advisors are ready to help you succeed. Good luck on your boards. You have got this. See you in the next video.